It's my pleasure to introduce Dr. Charles Friedman. He's the Josiah Macy Jr. Professor and Chair of the Department of Learning Health Sciences at the University of Michigan Medical School. He's been in this capacity since 2011. Dr. Friedman, this department is the first in the nation as a medical school that has an entire department dedicated to the sciences of learning at all levels from scale, from learning by individuals, learning by teams and organizations, to achievement of ultra-large-scale health systems. Prior to coming to Michigan, Dr. Friedman held an executive position at the Office of the National Coordinator. This included the role as the Deputy National Coordinator and also the ONC's Chief Scientific Officer. So this is an individual who knows quite a lot about the whole meaningful use. Perhaps over a beer sometime he'll tell you the inside story. While at ONC, he saw a wide range of activities, and he was the lead author of the first National Health IT Strategic Plan, which was released in June of 2008. Prior to his work with the government, Dr. Friedman was the Associate Vice Chancellor for Biomedical Informatics and the founding director of the Center for Biomedical Information at the University of Pittsburgh. He also had a distinguished career in a faculty and administrative role at the School of Medicine at the University of North Carolina, Chapel Hill. Please help me welcome Dr. Chuck Friedman. Big green button.
The green button.
Big green button.
Well, those lights are bright. There are people out there, right? Hi, people. Thank you so much, Tim. I really appreciate that introduction, and it's a pleasure for me to be here. I need to confess to you all that I woke up this morning with a really nasty summer cold. So, Tim, maybe you should sit a little closer to me, and you can either catch me if I fall over, or if I stop making sense, you can just kick me and knock some sense into me. I'm going to mention later this organization called the Learning Health Community, but I'm required to disclose that I am the chair of the interim steering committee of this group, and as I said, I'll refer to this later. So the main menu for my remarks today has three parts. I'm going to talk a little bit. I'm going to do this quickly because actually there have been presentations on the learning health system at the previous two incarnations of this meeting. Josh Rubin, you may remember his talk, those of you who were here last year, and I talked about the learning health system 2 years ago. So I'm going to run briefly through this, hoping that a review will suffice. And then I'm going to update you on national progress toward a learning health system. I think it's very important to emphasize that, to paraphrase a commercial that you've probably seen on TV, the learning health system is sort of the next big thing. It isn't here yet. It is, learning is more than connecting. Learning is more than exchanging information. It requires connecting. It requires exchanging information, but it's more than that. It's the grand goal. It's the big prize. We're headed that way. We're not there yet, and I'll talk about what the progress has been. And then I'm going to devote what I hope will be the bulk of my remarks talking about this very interesting initiative underway in the state of Michigan, a complement to everything you have heard about in this meeting, called Learning Health for Michigan, and I'll get to that in just a few minutes. So, what is the learning health system? Well, very simply, you'll see at the top what I think is the essential definition, the idea that health systems of any size or at any level of scale take on this property of becoming a learning system when they can continuously study and improve themselves. And I'll talk in a minute about, in a little more detail, what that means. And I know that many of you know this, but the learning health system idea has not been around that long. It was actually originated with the U.S. Institute of Medicine in around 2007 and has since then been written about by many authors in many places. So what does a national scale learning health system look like? It kind of looks like this. This is one way to draw it, and I think from this high-level picture, I would hope that three features of a very large-scale national learning health system would stand out. First of all, it is all-inclusive. All the stakeholders need to be engaged. If you leave any one key stakeholder out, I don't think a national or a learning health system at any scale will be stable. Most people believe the learning health system, in the spirit of the internet, will be decentralized. It won't be concentrated in any one place, and it certainly won't be driven off of one big central database containing all the information, because that is not only probably not the best way to go, it's also almost certainly not possible. And third, the learning health system is reciprocal. Its sustainability is based on a principle that all of these stakeholders who are part of the system will put something in, and all of them will get something out. And if the system is going to be sustainable and stable, the value of what they get out will exceed the cost of what they put in. Another way of looking at what a learning health system is to consider these 5 characteristics. You can almost think of this as a checklist. Is your health system a learning health system? Well, to the extent that it meets these 5 criteria, then it is. Is every consenting patient's characteristics and experience available for study? Can you learn from experience? Is the result of that learning, best practice knowledge, immediately available to support decisions? Does this go on continuously? Is this something that reflects the notion that we can always learn and improve, or is it bursty, meaning we identify a problem, we address that problem, and then we kind of go dormant for a while until the next problem occurs? In a learning system, this learning and improvement is continuous. Can you do this routinely and economically? Or is this something that shows no economy of scale? Every effort to learn and solve a problem costs the same as the previous one. And is this part of your culture? If people ask why you do this, is the answer, this is what we do here, this is who we are, this is what we are. If you can meet all 5 of these criteria, if a health system can meet all 5 of these criteria, then it's a learning health system. How do we learn? Well, there are a lot of approaches to this and a lot of ways to think about this, but a very simple one, and I actually call this the double helix of the learning health system, is to envision learning as a continuous process that involves and invokes the familiar concept of the virtuous cycle. We make a decision to study a problem of interest, a community forms around that problem, we assemble data to address that problem, we analyze the data, we interpret the results to see if we learned anything. There's a gap there to suggest that this is a point where there is always human intervention. The results of that learning are then applied to generate tailored messages to decision makers who will take some kind of action. Some will respond to those messages completely, others not at all, others in some intermediate state, and that changed state of the system, often reflecting improvement, but not always, will then drive the next cycle, and through successive iterations, progress will be made toward addressing the problem of interest. So a key point about the learning health system and what makes a learning process or a learning process into a process that can truly be called a system is that it is supported by an infrastructure. Having these learning loops in place will enable learning, but do not create a system because of the absence, unless you take effort to create it, of this infrastructure. And a simple way to think about this is if you want to get 350,000 people per day across a river, which is a problem the city of New York faced in the late 19th century, they could have built 350,000 rowboats, but fortunately they didn't. They built a bridge. And I guess since there's a Brooklyn, Michigan, this is an appropriate slide to show of the Brooklyn Bridge. So the infrastructure supporting a learning health system can be thought of as a platform, and not just a technology platform, but a people platform and a policy platform and a process platform that can support multiple simultaneous learning cycles. And through this existence of a platform, the platform being the thing that makes learning possible as a system, we can realize economy of scale. All of these different learning activities, each addressing different problems and each progressing at a different rate, each cycling at a different rate, get a float from this common platform. And in this way, the cost of running, say, 100 learning cycles is far, far less than 100 times the cost of running one of them. And my last point in this quick review about the learning health system is this wonderful property that it has, what mathematicians call a fractal, that learning systems can exist at any level of scale. You can have a learning health system at the level of a hospital. You could have a learning health system at the level of a region. You can have a learning health system at the level of a state, the nation, or as some have been envisioning, the whole world. And the key point here is that the scale of the system, a hospital, a region, a state, a nation, would equal the scope of the platform. And as I'll discuss in a moment, if we are going to envision a learning health system for the state of Michigan, we will need a platform, an infrastructure that spans the entire state. So, national progress toward a learning health system. A sort of preamble to talking about this national process is, I think, a very important notion, and this goes very much to my experience in the government, where the government seemed to feel that everything could be built from a blueprint or a roadmap. And in fact, just as the internet could not have been built from a blueprint or a roadmap, neither can an all-inclusive, ultra-large-scale learning health system. This is not like the process we followed to put a man on the moon in the 1960s, when we knew, when President Kennedy stood up in 1961 and said we would do this by the end of the decade, that all the problems had been solved, and it was just kind of a build-out from a blueprint that actually existed at the time he made that speech. The system is going to evolve through a complicated, much more bottom-up than top-down process. And in this spirit, we can point to 7 trends that are taking place across the country that together are characteristic of this bottom-up self-assembly that is going on. Some of these I will elaborate on. The ones, a couple I won't in the interest of time. I'll just refer to them here. So number 1 is words, policies, and reports. Very, very important. Number 2, which I won't elaborate on in another slide, is the rise in the extent to which healthcare is being documented in digital form. Without health data in digital form, it would be possible, but probably not very practical, to build a learning health system. And you see there on the right, the trend in this curve is the most important thing, the continuous, inexorable process in this country toward a digital health system. We are seeing the emergence of learning islands. These are entities that within their own boundaries are learning health systems. We are seeing the emergence of data federations and networks across the country. I'll say a little more about that. We are seeing federal agencies beginning to recognize the importance of this concept and beginning to, in various ways, invest in this with grants and contracts. We have seen the emergence of a grassroots national movement called the Learning Health Community, and we are seeing the emergence across the country of a group of researchers who are interested in solving the problems which must be solved if we're going to achieve a very, very high-functioning learning health system, because unlike the moonshot in 1961, all the problems are not solved, and we don't know how to do this with the level of effectiveness and efficiency that is going to be necessary to achieve the potential that the learning health system promises. So just to elaborate on a few of these areas of progress, there have been a lot of words, as I said, a lot of books, a lot of articles, but perhaps the most important words about the learning health system that have been written were written in the 10-year vision to achieve an interoperable health IT infrastructure out of my former office, the ONC. And this document, which I hope all of you have read, articulates the 2024 pinnacle goal for the nation's interoperability vision, that of the learning health system, very much as I've described it to you. So I think this notion wraps up what I said at the beginning of my remarks, that this is more than connection, it is more than exchange, it requires both of those. It's also more than big data. It's also more than precision medicine. It is the grand vision of what we can accomplish when we have everything working in sync. Just to emphasize these learning islands I referred to earlier, there are several of them. These are all organizations you've heard of: the Mayo Clinic, Kaiser, Geisinger, Intermountain Health. These are all organizations that I would argue have achieved all 5 of those characteristics of learning health systems. The limitation, of course, is that their achievement is bounded by the borders of their own organizations and affects directly only the patients who seek care in those organizations. But proof that it can be done, at least at that level of scale, exists in the success of those organizations in doing it. Complementing these achievements, these learning islands, are interorganizational data federations and networks that are increasingly coming together, focused on specific categories of health problems, but to do very much the same thing, to learn through this continuous process. And a few examples are shown here. Prominent among them, for our purposes, and I'll refer to them later, are the statewide collaborative quality initiatives, the CQIs, supported by Blue Cross Blue Shield of Michigan. But these are by no means the only examples across the country and around the world, and I've listed a few of them here. The grassroots movement resulted from a national summit, which I had the honor of convening about 3 years ago, which has given rise to this growing national community. The summit itself resulted in 10 consensus core values underlying a learning health system, and if you Google learning health community, you will be directed to the community's health site, and you can see what these core values are. But what's important now, as a key element of the evolution of this learning health system concept and the growing support for it, is that 78 on this slide, but now actually 80 to date, organizations, many of which you will recognize on this slide, have formally endorsed these core values as an expression of what their organization is seeking to achieve or is very much committed to support. And the key point I would like to emphasize about these endorsers is that they represent the full range of stakeholders who, per something I said earlier, must be engaged in a national scale learning health system if it is going to be stable. Lastly, a plug for my own department. I've been extremely fortunate to have basically convinced, for lack of a better word, the leadership of the medical school in Ann Arbor that it should have an academic department focused on this concept of learning, including but not restricted to learning as it applies to the creation and sustainability of very, very large-scale learning health systems. So this department is going to do research. We've just signed a contract to start a new academic journal called Learning Health Systems. It is going to educate people around these sciences and start a new PhD program, and then it is going to engage in service, which would be promoting learning and learning systems at all levels of scale, meaning helping organizations become learning organizations. So now to my third point, learning health for Michigan. So you saw before a picture of a learning health system, an illustration of what a learning health system might look like at national scale, with the backdrop being the whole nation. But I mentioned that learning health systems have this fractal property. They can be done at any level of scale, and at any level of scale they function pretty much the same way. So why not a learning health system for Michigan? And when I spoke at this meeting 2 years ago, this idea was very much in its infancy, and I could even argue that this idea was born at this very meeting 2 years ago. And there are a lot of reasons why we thought this might work. First of all, the power of the concept, and I hope in these very brief remarks I have convinced you to some significant degree of the power of this concept as endorsed by the ONC as its pinnacle interoperability goal for 2024. Through the Center for Healthcare Research and Transformation, led by Marianne Udow Phillips, who is known to many of you, we found a natural and appropriate and effective convening organization, and Babette Levy of the CHART staff is playing a lead role in advancing learning health for Michigan through her role at CHART. Babette, wave. Thanks for all your great efforts. These collaborative quality initiatives are learning health systems, each one of them at their own level of scale. So actually we had experience in statewide learning already ongoing in the state. And one of my profound beliefs that the best proof that you can actually do something is the fact that you're already doing it. So we were already operating continuous learning cycles in the state through these collaborative quality initiatives, and thank you to Blue Cross Blue Shield for getting this wonderful activity started. Of course, there is the tremendous progress being made in state-level health information exchange through MiHIN and all the sub-state HIEs. We received terrific support. I should be clear, we did not receive any money from the State Department of Health and Human Services, but through Megan Vanderstelt and her colleagues at the department, we received very, very important encouragement and other forms of support which are very key to get this kind of effort started. And finally, academic expertise, the know-how to do some of these things, not exclusively present at the University of Michigan, but certainly reflected in the commitment of the university to start the department I described to you. So Learning Health for Michigan took off from the idea that was presented here in 2013, and its key goal is to establish a common statewide platform to provide tools that can improve and accelerate healthcare. And notice the emphasis here on building a platform, on building an infrastructure. And to reiterate a point I made before, we really have to think about, if we are going to realize a learning health system at the level of the state, building a statewide platform that includes, I'll reiterate this because it's so important, not just technology, although technology is required, but also people organized in appropriate ways, policies that support all of this and process. I wish I had more time to talk about what exactly would go into this platform in more detail. I'll be happy to do that, or you can write to me about this, but there's another whole talk which there is not time to address today to talk about this platform in detail. So as I mentioned, these collaborative quality initiatives, the CQIs, give us an enormous head start because they are doing learning at the state level. Just a few of them are depicted here. I believe there are 29 currently in operation, and these do provide an important beginning. And here's how the chronology of Learning Health for Michigan, or LH4M, as we sometimes call it, has unfolded. I mentioned the origination in May of 2013. This led to a decision by CHART that they would serve as the central convening organization, and they began to convene a planning group whose main goal was to plan a multi-stakeholder meeting that would occur in the next year. And quite honestly, as we were planning this meeting, we had no idea if anybody would come. Well, we held this meeting in July of 2014 at the Radisson across the street, and we thought we might get 50 or 60 people, and lo and behold, we had 105 participants there. And if I can editorialize, the real barometer of success of a meeting like this is not how many people are there at the beginning, but rather how many people are there at the end. And I think 80% of the people who were there at the beginning were there at the end as a testimony to the success of this meeting. And this meeting spawned 7 theme groups, call them 7 nascent problems of interest around which these learning cycles, these statewide learning activities might form. Recognizing that we had already in the state these CQIs as learning organizations, we made an outreach to some of them to see if they would like to connect themselves, at least in principle, to Learning Health for Michigan, and I believe 3 of them expressed interest in doing that, which is about the level at which we hope we would start. Not listed on the slide, but very important, coming out of the July 2014 meeting, we formed a planning and coordination group for Learning Health for Michigan, which has 20 members that I believe represent 15 different organizations from across the state. Again, the importance of multi-stakeholder approaches. In the fall of 2014, we formed a platform group which is beginning to consider the design of this infrastructure, building on top of many of the health information exchange activities that are already going on in the state. And I will give you 3 guesses at who was the chair of that platform committee. You won't need 3 guesses because clue number 1 is that he is sitting directly to my left. So we're delighted that Tim has agreed to chair this platform team. And these theme groups, which were spawned by the Lansing meeting last year, have begun at various paces to begin to conceive how they might organize into statewide learning cycles. Here you see on this slide, and I won't read this, 4 of the theme groups, and each group has what we call champions. They're not formed to the point that we would call them chairs or leaders, although I think they will evolve into those roles. These are the two that focus on the public health agenda and the consumer agenda, and then there are three more that focus on the provider agenda, and a very interesting idea that this learning health system approach might be used and might be essential to efforts to strengthening the healthcare workforce. I'm not sure if you'll be able to read the small print here, but the arrow is the important message that we are making progress. The theme groups are developing. We are beginning to engage with selected ones of the CQIs, and the platform team is starting to meet. So to wrap up these remarks, where are we going with Learning Health for Michigan? What are our next steps? I think it's fair and important to say we are facing a challenge with funding. One might say, just like some of the challenges being faced in the discussions around repairing the highways in this state, I think it's just the way of the world that while people will pay for projects focused on specific goals, it is much harder to come to grips with who should pay for infrastructure. And the Learning Health System and Learning Health for Michigan is very much around infrastructure, and we are challenged to, as worthy as this goal is, and as many people who believe it's important to do this, find a source of funding to build this platform and build this infrastructure. But other things that are going on as we seek funding is the continued maturation of the theme groups. As I mentioned, we are designing the platform components. We're working, because they are already engaged in learning activities, we are working in collaboration with several of the CQIs, and we very much hope to grow what I think we are increasingly going to call the Learning Health for Michigan community. And if you would like to be part of this community, I'm going to flash my email address in just a moment, and please write to me. And actually, you can, even better, I forgot this slide was in here, you can contact Babette and go straight to the most important person. If you're interested in joining the Learning Health for Michigan community or learning more about what we are doing, or give us money, you can contact Babette, but of course you can also contact me. Roll the tape back to yesterday and the movie, No Matter Where, which I hope many of you enjoyed. I want to reiterate, for those of you who did not see the movie but would like to, there will be another public screening in Ann Arbor on Monday, June 29th, with the producer, Professor Kevin Johnson from Vanderbilt there at the Michigan Theater. And that will be followed, and this might be of interest for those of you who did see the movie, by a panel discussion on the morning of the next day, Tuesday, June 30th, in Palmer Commons on the Michigan campus. If you are interested, there are flyers about this available in the exhibit room out there, and there are several of them at the MiHIN desk, so you could stop by and pick up a flyer. So that brings my remarks to a close. I hope I've engaged you in and helped you to recognize the importance of the big, hairy, audacious goal of the learning health system. I hope I've given you a sense that this concept is achieving a great deal of traction across the country, and there are many directions of progress. And I hope I've interested you in becoming part of our own efforts here in the state to realize a learning health system. Well, thank you very, very much. Thank you. Thank you.